Hello, this is Dr. Turkman, and this is a case of a white liquefied cataract with a calcium plaque in the anterior capsule. So, as you very well know, the main challenge here will be capsulorhexis. It's also a rather young patient, so even in the healthier areas of the anterior capsule, there is a tendency for such an elastic capsule to uh, tear radially. So, the main challenge here will be to perform the capsulorhexis in the fibrotic areas of the capsule. This is very large to go around it without risking the rhexis tearing out. So I have to use the scissors to cut through the fibrotic areas. So not only I have to cut in the peripheral area to be able to make my rhexis progress, I have also to cut in the center, so the length of the flap will be enough so that the vector forces applied when I'm progressing with my rhexis can be more predictable. You can see how liquefied the cataract is, and as I injected some viscoelastics, the cataract was rather being pushed away. Now I'm progressing with my rhexis, and again I'm finding a second challenging area. The calcium plaque goes a bit farther than you can actually see in the video, so again I have to cut in the periphery, and unfortunately there, after I do the cuts, some of the soft lens matter prolapsed and made the anterior tear to go actually quite radially, more than it looks in the video. So it's all about understanding the vector forces. If the zonules are pulling outwards and I want the rhexis to continue in a circumferential fashion, then I have to pull centrally, so the resultant force will make my rhexis go where I need it to go. So we've managed to retrieve the rhexis, but as you can see, even in the healthier areas, there is a tendency for the rhexis to tear out, so we have still to be careful. And we finally complete a rather large rhexis, but still curvilinear and continuous with no spike. So with an appropriate technique, the rest of the procedure should be very safe. I soon realized that the cataract is very soft liquefied, so no that much of a need for phacoemulsification, but rather phacoaspiration. I'm also doing some polishing of the posterior capsule to prevent from early posterior capsular opacification, and then I will place the lens in the capsular bag. And since the rhexis was larger than desirable because of the calcium plaque, I'm putting some myocl to ensure that the anterior chamber will remain deep and that the lens won't move forward soon after surgery. So the case is over. Thank you very much for your attention.